So welcome to our webinar. This is a really exciting topic that we're going to be talking today with three experts on, and that's really health innovation and the relationship really to private equity and capital markets. And as we move forward, you know, is it really driving innovation, and how important are those markets for innovation as we go forward? So we all know, anyone working in the healthcare space, just how important really, innovation, digital, different kinds of ways in which we engage with healthcare are integral to really meeting the demand, which is really outstripping the supply across healthcare. The pandemic, of course, has not made it any better. But many of these challenges we were facing long before before the pandemic. What has really, though, been the impact of the pandemic is helping us realize that we can scale quickly, that we can bring innovation, digital, both in terms of biotech, pharmaceuticals, and really hospital care, pathways. We see a lot of use of remote patient monitoring, different devices. All of this, though, takes research and investment and to really develop these products and to launch them into the market. So we've seen lots of angel investors come forward. We've seen more and more money in various stock markets, the impact, particularly in areas like biotech and pharmaceuticals, really launching forward with large kind of mergers, acquisitions, lots of small companies being taken up by larger companies. So what does that all mean for health innovation? And we also see particularly a huge funding gap for low and middle income countries. So is it also a route for them? How can they drive forward demand and innovation and in this space? So this is really what we've asked our three speakers to focus on today in this webinar. To whether or not capital and private equity markets are actually driving forward better healthcare, and are they really integral to health innovation as we go forward? So just quickly, I'd like to introduce the three speakers that we have. The first is Chris Laing. He is Associate Professor and Vice Dean Innovation on Entrepreneurship at NUS Duke in Singapore. He previously, Chris was the inaugural director of Capital City Innovation, where he coordinated stakeholders in the kind of an innovation district around Austin, Texas in the United States. And this was a real new health complex. Chris has spent most of his career driving and championing innovation, particularly in this sector. And so it's really a delight to have you with us today, Chris. I've also got with me Ezra Mehlman. He is a partner at Health Enterprise Partners in New York, an equity firm focused on healthcare, IT, and services. Ezra also teaches decision, risk, and operations at Columbia University in the United States. He also has spent most of his career in the healthcare and finance space and comes with lots of experience and expertise. And then last but not least, I've got Pettifor. She is a political economist and a researcher in global finance and monetary policy. She's written extensively about financial markets and the role that capital and equity markets play within the larger economy and society. So welcome to all three of you. We're going to start out by giving you the opportunity to really talk a little bit about this important question and this space. And then, of course, we'll take questions at the end. So if we can start with you, Chris, it would be great to have you share your views.
Yeah, great. Thank you, Nora. Delighted to be here. Thank you for inviting me to participate, and great to be here with Ezra and Anne. And yeah, looking forward to the conversation. And I thought maybe what I'll do is to get started. I mean, you've already given maybe an introduction of me, but I think maybe I'll set the tone by talking a little bit about my perspective and the organization that I'm with right now, and then how we are and what I do intersects with the topic that we're talking about today. So maybe I'll start off by with the confession that I am a scientist originally. So that was, I did my PhD many years ago in Australia, which is where I'm from originally, and moved to the US to do postdoctoral training. And it was there that I first came across the idea that the research work that I was doing could ultimately be directed towards product development as opposed to testing hypotheses. And I had never really sort of understood or come across the concept of technology transfer before I did my postdoc. But while I was doing my postdoc, I sort of learned about this whole mechanism that was focused on taking research discoveries that were coming out of the labs at the university and transitioning them into product development pathways that would ultimately result in outcomes that could be actually utilized to benefit patients. And so when I finished my postdoc, I jumped ship. I ended up working for a couple of biotech startup companies that were spinning out of the medical school at Penn, which is where I've been doing my postdoc. And that took me eventually to an organization in Philadelphia called the University City Science Center, which is a nonprofit organization that was developing essentially an innovation district in the West Philadelphia region. And the whole purpose was to build infrastructure that would allow companies and universities to interact with one another and to ease that transition of ideas out of the research labs and into the hands of either startup companies or larger companies. And fast forward, my career took me to Austin, Texas, and now I work at GKNUS Medical School in Singapore. And my role here at GKNUS is to oversee the office from the academic side that is responsible for the activities that I just described. So our tech transfer department sits in my office, and our industry alliances sit within my office. And I also interface with our healthcare system, which I'll talk about in one moment. And so my responsibility at GKNUS, the medical school, is to help to put in place frameworks and infrastructure and support that will make it easier for our researchers to interact with and collaborate with the private sector, either investors or companies. Maybe just a couple of minutes on GKNUS and our healthcare system, SingHealth, the partner. So GKNUS is a relatively new medical school. It was formed in 2005. And as the name suggests, it's a collaboration between Duke University in North Carolina in the United States and the National University of Singapore, which is a fairly highly ranked research university, multi-collegiate research university here in Singapore. We're the second medical school in Singapore, but we're a little bit different from the other two medical schools now that are here in Singapore, in that we're a hybrid graduate model. So we've taken the US model and are of graduate medical education and research intensive medical education, with the idea being that what we aim to do is to train not just the next generation of physicians and clinical practitioners, but really the thought leaders that will drive health innovation and cutting edge medicine in our academic medical center. So we emphasize what we call a clinician plus strategy in terms of educating our physicians. Our healthcare partner is SingHealth. So SingHealth is a healthcare system here. It's a public healthcare system here in Singapore. It's actually Singapore's largest group of healthcare institutions. SingHealth as an entity was created in 2000, but it includes hospitals and institutes that have been around, including some of the oldest And the oldest hospital here in Singapore, Singapore General Hospital, is part of the SingHealth family. And it really spans the continuum of care from a network of primary care clinics through to 4 general hospitals, community hospitals, and national specialty centres. And we see about 50% of Singapore's public patients here. And one of the reasons that partnership is so important for what we're talking about in my job and what we're talking about here today is because together the GKNUS and the research labs, both at GKNUS and in the national centres, are partnering then with the clinical organisations that are actually dealing with patients on the ground. So we're seeing everything from the entire continuum from discovery all the way through to bedside. We're a relatively small but targeted medical school. So just GKNUS, to give you a sense, our research expenditure is about $100 million a year. But we're focused very specifically in 6 areas that are strategically determined on the basis of our need here in Asia. So we work very much on cancer, and particularly cancers that are relevant to Asian patients, on inflammation, and of course infectious diseases. Of course, the last 2 years has seen us very focused, as many medical centres, on coronaviruses and on cardiovascular and metabolic diseases, but also on health systems and health services. And importantly, about 10 to 15%, it varies from year to year a little bit, of our research activity is actually being driven by private sector investment. So either investors or pharma companies or medical device companies that are driving research and development in collaboration with GKNUS and our academic researchers. And there's really 3 different ways that we partner with those private sector collaborators. The first one is research collaborations. So we put in place in any year probably around 40 or 50 new industry collaborations that are focused primarily on co-developing new ideas and new products that may either originate from the companies or in some cases originate from our own labs. The second way is in licensing intellectual property that arises from within our medical school. So typically when our researchers invent something and we patent it, we will seek out partners in the private sector, either investors or companies who typically through a license agreement would get access to that intellectual property and enable them to then further develop it as a product and commercialize that invention. And just to give you a sense, at GKNUS, we probably do somewhere between 5 and 10 of those types of licenses a year, including probably about 1 or 2 startup companies that we launch. I'm happy to talk a bit more about that. And then the third way in which we intersect with the private sector is typically in helping to build models of adoption and testing for technologies, and particularly for technologies that are in the digital space. This becomes a particularly important form of partnership with the private sector in piloting and ultimately validating and scaling new technologies that are relevant for solving the challenges that we may see in clinical practice in various different areas. And maybe I'll just finish by, before getting into the discussion with the others, by talking about 3 quick areas that we're looking at moving forward. 3 challenges that we have on our horizon. One of them is in talent development. So we continue to be very focused on how do we continue to train entrepreneurs that can help to drive those types of relationships that we engage in. The second is in creating infrastructure that allows companies to actually take footprints alongside. It's a topic that's quite dear to my heart because of my background in working in innovation districts. And then the third is in global health. And I'm looking forward to talking more when we get onto LMICs Singapore, we are a very small market in a region that shows a great deal of diversity in terms of the healthcare systems and the patients across our region. And so we have a fairly strong program in global health that is very focused on the Southeast Asian region. And innovation is one of the key pillars of that global health program. So maybe I'll pause there and looking forward to further conversation during the Q&A.
Okay, thank you so much, Chris. And I'm going to now move over to Ezra.
Thank you, Nora, and great to be with all three of you, as well as the international set of attendees we have here. I'll be very brief as I'm looking forward to kind of getting into the discussion. But I was reflecting on the topic of this panel, which was health innovation through capital and private equity. And I think that it invites sort of two embedded questions. The first is private equity driving innovation in healthcare? And the second is private equity a force for good in healthcare? And I think both can be sort of hotly debated. So perhaps I might just focus on the first, because they are rather distinct questions. You can of course have unconstructive types of innovation, and you can have positive types of innovation. So is private equity driving innovation in healthcare being sort of the launch off point for our discussion? Just by way of a slightly more robust set of context on who I am. So my name is Ezra Mehlman. I'm a managing partner at a firm called Health Enterprise Partners. We're a healthcare IT and services focused growth equity firm. And I also an adjunct professor at Columbia Business School, where I teach a class on healthcare venture capital and private equity. But the unique aspect of our group is that the majority of the capital that we manage, so the majority of our limited partners are nonprofit hospital systems and healthcare insurance companies in the United States. And so our model is that we work with these LPs, these strategic LPs, to identify sectors that are responsive to their up at night issues, to their top pain points. And then we target investments that that map to those areas of focus. And when the model works well, our limited partners, U.S. hospitals and healthcare insurance companies can help drive sort of the commercialization and customer relationships with these companies, as well as serve as a really, really valuable sounding board in diligence. So I offer that context just to say that as a private equity investor, our particular model is that we are constantly engaged in discussion with these health system leaders around what their innovation priorities are. Where are they seeing opportunity? Where are their pain points? And that is translating into our investment agenda, our sectors of focus for the year. And I would represent that in and of itself, identifying areas to deploy capital that are responsive to the innovation pain points that are plaguing hospitals and health plans, that in and of itself is a form of innovation. So, again, just remaining consistent by sort of exploring this question of, is private equity driving innovation in healthcare? I think that one could point to a number of sectors that have been bolstered and in some cases uniquely created by venture capital or private equity investment in healthcare. Just to name a few, virtual care and telemedicine. It is difficult to imagine the scaling of that industry without the presence of a robust private funding market. The largest names in that space, whether it's Teladoc or American Well or any of the other sort of public companies, they all began as private companies and they were funded by the venture capital community. Remote patient monitoring, another sort of sector that was really kind of bolstered and commercialized by the venture capital. In the United States, we use the term value-based care. There's a number of value-based care companies, so companies that are helping healthcare providers take risk on patient populations, that the entire funding model is a product of private ownership structure, where you could have pools of capital created to go onto the balance sheets of providers to allow them to enter into innovative risk-sharing arrangements and get out of the fee-for-service kind of volume-based healthcare system we have in the United States. And a lot of that innovation, I think, I would argue, is due to the presence of the venture capital industry. Now, you could argue that the progress hasn't been consistent enough in value-based care or in quality-based contracting in the United States, but I think that it would be hard to argue that the presence of a private funding option hasn't been one of the things that's birthed all these different companies in that space. Bundled payments analytics and the entire sort of IT infrastructure around patient payments is been a really, really hot magnet of venture capital, in the United States. And then, I could keep on going, but I would say healthcare cybersecurity would be, another kind of industry that has attracted a lot of private capital. That would be hard to imagine, had there not been sort of a robust private equity financing mechanism, at least here in the U.S. So I think that would sort of act, that all those would serve, sort of in service of this kind of question of whether private equity is driving innovation in healthcare. I opened just a second lens here. I opened the discussion by mentioning that a big part of our effort, my personal effort, is to survey the different pain points that are affecting these hospital systems and healthcare insurance companies in the United States as a way of identifying sectors of focus and problem statements for companies to solve, which I again think is a form of innovation. And just to give the audience a little bit of visibility into some of the things that we're hearing today and themes that we're actively seeking to invest behind as a result of that. Leveraging technology to respond to the labor shortage here in the United States. Lots of discussion of the Great Resignation and hospitals being strapped for nurses. So identifying technologies to force multiply care teams and help hospital systems do more with less. Really, really key theme. Responding to the opiate epidemic, which is really, kind of crushing, sort of the fabric, of this country, and others. And so thinking about innovative approaches to substance use disorder, really, really kind of key, area. Administrative cost automation. So with this kind of crippling financial blow that COVID, dealt to a lot of hospitals, in particular here, lots of focus on where can you eliminate unnecessary cost, through technology. And then I would say a top one is advancing health equity, and that this idea, which may have been sort of called social determinants of health for a while, in sort of circles, I think has evolved into a broader kind of health equity view that the wide variance in outcomes and access across different demographic groups, needs to be corrected with sort of deliberate approaches, and that technology serves kind of a role in that. So, that would be a sort of a second lens of how private equity is focusing on issues that are top of mind for healthcare leaders and trying to drive innovation. Just to kind of wrap up with two more perspectives. I think we can also examine this question of is private equity driving innovation in healthcare, from this kind of and I know we have a real economist on the line here, but from the sort of classic Schumpeter view of creative destruction, are the forces of creative destruction present in sort of private healthcare markets, are the young, scrappy companies, laying siege to the business models of these sort of sleepy incumbents and rendering them outmoded, and eventually those kind of young, scrappy companies are becoming the acquirers. For a long time, I would say that the pace of that kind of creative destruction is not occurring fast enough in healthcare. I would argue that it has really started to accelerate. And I think one metric that you could point to is that healthcare IT companies, so digital health companies themselves, have become the acquirers of other healthcare IT companies in greater than 60% of the cases. So whereas before you would have a small startup that would be sort of conceived with the idea of selling to a larger, sleepy, multi-vertical, type of company, a lot of times these startups have now evolved into the acquirers of other startups. And and that actually is occurring in more than half the time in the acquisition of healthcare IT companies. And I use data from Rock Health sort of in support of that. So just in closing, I think it is, I think you can tell where my head's at in, sort of messaging that healthcare private equity is a force for innovation, but I would argue that it is not always a force for good, and that not all innovation is good. I think that you could point to corporate governance oversights of the private financing model that would be probably less prolific in the public markets with the scrutiny of a public market board. And you need not look any further than businesses like Theranos and some of these high profile, former Silicon Valley unicorn flameouts, where there was a tremendous amount of private capital accessible to businesses that were either engaged in outright fraud or something less than that, but inadequate controls that I believe were a product of the private financing market. And then I think you could also point to other subsectors within healthcare private equity where asset values have gotten sort of bid up to very, very high levels, and the actual value that was generated by those platforms was sort of insufficient and in order to help the private equity firms realize an exit. And as a result, a lot of value was destroyed. Businesses, kind of went under. People point to the original set of roll-ups of physician practice companies in the 90s as an example of one sort of private financing strategy that spectacularly failed. And now we're on sort of physician practice management 2.0, cognizant of the issues of the past. So that is what I would say, and I am glad to turn it over to my fellow panelists here.
Thank you so much, Ezra. So Anne, I'm going to turn it over to you now.
Thank you very much, Nora, and thank you for having me, and thank you to Christopher and Ezra for their contributions. Now, we've been asked to discuss whether capital and private equity markets are actually driving forward better and sustainable health innovation. And I'll argue today that private capital and private equity markets, far from driving forward sustainable health innovation, are contributing to rising rates of mortality from preventable diseases worldwide. The most egregious case of this failure of private capital to support sustainable health innovation was made stark by the COVID-19 pandemic. And my case rests on the experience of COVID-19 in Africa, and more specifically, the experience of the innovative and publicly financed South African Centre for Epidemic Response and Innovation, to which I will refer below. But first, the wider context. 21st century capitalism bears little resemblance to the capitalism that fired the Industrial Revolution, or indeed the more recent Thatcher-Reagan model of capitalism. Key sectors of today's new hyper-capitalism are profoundly risk-averse. As Professor Kay Susan K. Sell argues, economic power has shifted from the mainstays of the real economy, commodity producers and traders, to the controllers of global value chains who own intangibles such as intellectual property and financial instruments. Intangibles, especially IP, now have an outsized role in the global market economy. Collecting rent on existing and often publicly financed intangible assets is far more profitable, say, than investing in the making, manufacturing, and trading of commodities and goods. The key difference between the value of the trade in commodities and manufactured goods and the trade in intellectual property is this: IP prices are underwritten by taxpayers. Unlike commodities and manufactured goods, IP prices are not subject to market forces of supply and demand. Instead, prices of intellectual property are protected and enforced by the strong, and in the case of the United States, the long arm of both national and international law. A second feature of today's capitalism is the prioritization of rents, profits, and capital gains over the expansion of investment, innovation, and employment. And I'll expand on that. The third is the pursuit of competitiveness, not competition, in global markets. In other words, states tolerate oligopolies at home, monopolies and oligopolies at home, to ensure competitiveness abroad. Think of Apple and Amazon, Pfizer and Moderna, Alibaba and Samsung. So today's hypercapitalism has led to economic concentration, oligopolies, obscene levels of inequality, and a reduction in competition at national and global levels. The absence of competition, combined with the underwhelming levels of private and public investment since 2007-9, and coupled with private risk aversion, limits the possibility, I will argue, of experiment and innovation in healthcare. Collecting rents on existing and taxpayer-funded assets and not innovation is the core business of every capitalist pharmaceutical company and its investors. And that core business, to control and capitalize on intangible assets and thereby to maximize shareholder value and generate large rents, is achieved at the expense of the state, i.e. taxpayers, and of health innovation. This protection of private risks was negotiated after extensive lobbying during the Uruguay round around the General Agreement on Tariffs and Trade in 1986-94, when trade policy was linked to intellectual property standards. The US strategy of linking trade policy to IP can be credited to senior management at Pfizer, who in the early 1980s mobilized corporations in the US and made maximizing IP privileges the #1 priority of trade policy in the United States. As a result of this form of protectionism and its powerful enforcement mechanisms, 21st century capitalism bears a closer resemblance to the Soviet-led centrally planned economies of Eastern Europe, for it is the most basic preconditioning for the functioning of the free market mechanism that economic decisions must be accompanied by co-responsibility. Whoever takes economic decisions must also carry financial risks. If this link is severed, as it was in the centrally planned economies of the former Eastern Europe, Soviet-style capitalism is the result. Hiding behind the WTO's trade-related aspects of intellectual property rights, TRIPS, global pharmaceutical corporations work hard to sever this link, to avoid risk while maximizing capital gains and profits. They do so by being parasitic, I argue, on the state, or more accurately, on taxpayers. During the global pandemic, 4 areas of risk were de-risked for private investments in big pharma. These were preclinical investment and scientific risk, human testing risks related to safety and efficacy, manufacturing investment and risk, and market risk. In the US, in addition to decades of government funding for research prior to the pandemic, US taxpayers added significantly more support during the pandemic to further accelerate vaccine development and capacity. Most recently, the Congressional Budget Office estimated that the Biomedical Research and Development Authority, BARDA, alone has spent $19.3 billion on COVID-19 vaccine development. In addition, Lisa Cornish has projected that $39.5 billion was spent in US spending on vaccines. So we have instead to look to public institutions, such as the South African Centre for Epidemic Response and Innovation, for the real risk-taking and innovation. First, a declaration of interest. I am a South African born, and most of my family still live in South Africa. To date, South Africa has only been able to vaccinate 24% of its population. Malawi and Zambia have fully vaccinated a mere 3% of their people. However, thanks to previous epidemics, notably HIV, the South African Centre for Epidemic Response and Innovation and its state-of-the-art genomic centre at the Faculty of Health and Medical Sciences at Stellenbosch University is one of the most innovative in the world. The centre is funded by the South African government, the university, and by charitable foundations. Professor Túlio de Oliveira and his team have produced the best science on COVID-19, I would ask. They were the scientists who first alerted the WHO and other authorities to the new Omicron variant. Using over 100 samples from over 30 clinics in Gauteng, Johannesburg, South Africa's global transport hub, they started genotyping and quickly analyzed mutation of the virus. They linked all the data with PCR dropout, the increase of cases in South Africa, and the positivity rate, and began to see it might be a very suddenly emerging variant. From the time they discovered the variant and then confirmed its existence to key ministers and the president, before going public, was around 36 hours. Global pharmaceutical companies effortlessly made billions of dollars in profits from the South African discovery of the Omicron variant. Moderna's shares skyrocketed after the South African announcement and settled at $310 plus a share on Wednesday, the 1st of December, 2021, up nearly 14% from Wednesday, 24th November, the day before the announcement. Pfizer's shares rose by 7.41%. Moderna's CEO, Stefan Bancel, personally became more than $824 million richer in the week after the announcement. He sold off 10,000 shares for $319 each on the 26th of November, the day after the variant was announced, cashing out $3.19 million. Bancel has refused to share the recipe for Moderna's vaccine with the WHO to help scale up manufacturing and mRNA vaccines through its new hub in South Africa, where WHO scientists are now trying to reverse engineer the vaccine. Last week, the WHO announced that 6 African countries will be the first recipients of the mRNA technology from the Cape Town hub, which expects safety trials for the new mRNA vaccine to begin later this year. But in the absence of an IP waiver, the burgeoning tech transfer initiative could face legal challenges from pharmaceutical giants. Moderna has thus far refused to cooperate with the WHO's mRNA hub, which is currently working with facilities in Argentina and Brazil in an effort to further expand vaccine production capacity across the global south. Professor de Oliveira, CEO of the South African Centre for Epidemic Response and Innovation, told the BBC recently, and I quote, that global companies refuse to share the IP even after they made billions of dollars from our discoveries. We've been persistent. We've decided to go to open data, especially Moderna, and have managed to develop the full proof of concept similar to Moderna, the production of vaccine, which could be approved in 2024. But if we had the IP of the other vaccine, that process would take much less time. In South Africa, he said, we've not given up. To conclude, and as Amnesty International have argued, pharmaceutical companies knew that grotesque levels of vaccine inequality would create prime conditions for new variants to emerge. They let COVID-19 spread unabated in low and middle income countries. And now the same pharma execs and shareholders are making a killing from a crisis they helped to create. Making a killing from a crisis they helped to create. It's utterly obscene, end of quote. And despite the millions of deaths from COVID-19, still the big pharma companies continue to hide behind the protectionism of the long arm of international law and refuse to share the largely taxpayer-financed recipe for vaccines. That is bad for innovation and health and bad for millions of people and their families dying of preventable diseases. As Professor Mariana Mazzucato, professor in the economics of innovation and public value at UCL, has argued in her book, The Entrepreneurial State, risk-taking by government agencies has nurtured almost all of the key technological advances of the last 40 years, of the last 100 years. Apple iPhone, GPS, touch screens, and the internet all originated with government agencies. And risk-taking by governments, not private capital, have led to the most important health innovations of the recent past. Thank you. I hope that was 10 minutes or less than 10.
Yeah, thank you so much, Anne. So really great and very diverse perspectives. So I'm really looking to the audience to generate some questions. While I'm waiting on the audience to do that, I want to just really, Chris, start with you. Anne and Ezra, Ezra has done told us a lot about his perspective and the role that private capital and equity markets and have been playing, and Anne is kind of come in there really with the eye really on the idea that actually they haven't really made much of a difference. It's really been through government funds and funding that we see most of the innovation in the past and in the present, and actually, if anything, markets have been distorting things. So Chris, I come back to you, because at the very beginning you gave us a real holistic kind of introduction to your organization, the kind of the medical center, the kinds of innovation that you do, and your experience there in Singapore. What do you think? How would you, from a kind of lens from Singapore, what do you make of that idea that it is really, same as usual? It's the government, it's the taxpayer that's really at the heart of driving innovation, and markets, for lack of a better word, might be a bit of noise.
Yeah. Great set of perspectives there, and I heard things. Frankly, I heard things from both Ezra and from Anne that resonate with me, and I'm going to, and there were perhaps themes in both that were a little bit above my pay grade as well. But I will, maybe what I'll do is to share the perspective. I'm going to take the part of an academic institution, right, and maybe speak on and echo what I hear from the researchers that we work with. And I think, I don't know exactly who is in the audience here today, but for those of you who know scientists and people who go into academia, I mean, almost 10 out of 10 of them go into science and academia because they have a burning desire to discover new things and to do some good in the world, right? I mean, they want to contribute something. Yeah. And so I think I heard, from what Anne was saying, something that resonates very strongly with me, and that is that a great deal of the innovation that comes out of academic institutions is driven by public sector support. I mean, I think that's without doubt, right? And that is the gas that keeps the academic engine going, in terms of innovation, in terms of new ideas and new solutions. But I will tell you that what we hear is that it's that mile that goes from making the discovery to getting to the patient where often public funding, at least in my experience in the areas, in the geographies in which I've worked, runs out, right? And so, I think that one of the things, we as an academic institution, and me in terms of my office, we seek out private sector partnerships simply because there are fewer public sector options available to us to take new discoveries and transform them in such a way that they can be properly tested through regulatory pathways, manufactured and ultimately delivered. Those are things that typically are not publicly funded. And so I'm sort of driving the car down the middle here because, my office really is about making that jump from the public funded piece through to, so I think to finish that thought, I think it partly depends on what we mean by driving innovation, right? Certainly, I agree that the majority of inventions and ideas and discoveries are coming out of public sector funding. But if we define innovation as being the manifestation of a new idea in service of solving a problem, typically that happens when the idea becomes an actual product. And I would suggest that in my world, the majority of that is being funded out of private capital rather than the public sector, rightly or wrongly. And I don't have a sort of an Earth version 2 that has gone in a different direction to really know, but that just is the reality of where we live as academic institutions in this space.
Great. Thank you so much, Chris. So Ezra, there's a question for you from the audience, and it says, what are the main challenges for private equity funding companies, and particularly in escalating help for small unicorn startups in the global market?
Small unicorn startups, a little bit of a contradiction, I guess. I suspect the question may be coming from an entrepreneur in the audience, I think my general view is that it's never been easier to raise capital. There is an overabundance of private capital in the regardless of whether or not the entire panel here would agree or think it's a positive thing, or think that that capital has enough sort of risk attached to it. But there's plenty of capital, at least here in the United States, for startups, and I think the bar has started to be raised a little bit in this kind of post pandemic or pandemic phase 2 or 3, or wherever we are world, on what the go forward utilization of a lot of these digital health technologies, assuming this is a digital health entrepreneur, will be. There were, tremendous sort of, spikes in the utilization of things like telemedicine and, asynchronous care and text-based approaches to care coordination, that on the backs of that utilization, a lot of companies raised a bunch of money. But now I think that there's a little bit more sort of sobriety and a focus on results and ROI, and it feels like a little bit more of rationality is being sort of injected into the system. And so I think that a focus on that has been sort of reintroduced here. If I could just pose a question to
I thought you were supposed to answer them, but we'll let you pose one as well.
Sure. And a lot of what you said resonated with me. Not sort of responding directly to some of the broader structural, issues you presented, but instead maybe asking, two rather specific, questions. So, if you just reflect on the state of private funding, private money going into healthcare technology in the United States, and depending on which set of numbers you looked at, in 2021, there's $28 billion invested in venture capital investment into digital health tech. Just as a marker, in 2020, there was $14 billion. So, and that was already a record. So twice as much, kind of went in. I think the question on that would be, does that capital have an insufficient level of, is that level of capital insufficient, that there needs to be more, investment, or is there not enough risk, sort of being assumed by the investors who are, writing those checks? I think that was sort of one theme, that the risk, sort of equation, that there's not enough risk being taken by private capital, and that's the role that private capital should be assuming. And then I think that's just the second question would be, and I don't want to hog all the time, but if you look at like the utilization of private technology, which was frequently life-saving, private funded technology during the pandemic, the fact that virtual care visits went from 2% of total volume to 50% of total volume for a lot of health systems, because that was the only way that they could deal with patients. And the fact that those companies were, incepted by venture capital firms in many ways, how does one sort of square that with this, idea that, that these firms are taking sort of insufficient risk, and that there might be, and that the role that, should the government have stepped in here and, kind of created some of these platforms, themselves?
So Nora, do you want me to answer those questions, or do you want to ask me to address one of the questions from the audience?
Yeah, sorry.
Yeah, no, I think that's fine. If we could combine it with one of the questions from the audience, and that is, so there is a question here saying, if state-sponsored innovation is the best, and I'm not sure that's exactly what you were saying, but how many states have the size, the funds, the expertise, the long-term vision to create DARPA-like organizations? And I suppose in a way that also it resonates kind of with the questions that Ezra is putting forth.
Sure. There are states like South Africa that don't have the kind of taxpayer base that the United States has. And the public institutions, including monetary institutions, that the United States enjoys. Indeed, there's no other state in the world that enjoys the privilege of issuing the world's currency, which the United States is able to do. So there are states that, by the virtue of their size, are better equipped. But I think my point is this: that the system has been so constructed since the introduction of TRIPS in the 1990s as to kind of generate a new kind of capitalism, which I see as parasitic, which I see as being extractive and not innovative and constructive. The old-fashioned idea of capitalism, which is that you take risks in order to innovate, and that you're allowed to enjoy the capital gains or the profits from that risk-taking, that has gone out the window. So in the case of the $28 billion invested in digital health, well, I mean, and that's easy money, because the infrastructure, the digital infrastructure, has been financed and established by the American states, as Mariana Mazzucato so eloquently demonstrates. All of the infrastructure, which is now makes digital investment possible, investment in digital assets possible, was funded by the U.S. Department of Defense largely, right? So I'm not saying that we need to have. I mean, I'm absolutely saying we don't need Soviet-style capitalism, which is what we have. I think we need a kind of mixed economy, and I think the private sector has a really important role to play in innovation. What I find so awful is that the way the private sector is now constructed is to not innovate, to not take risks, but simply to feed on the value they can extract from the state and from taxpayers, because that's easy money. And so the investment in digital health is an investment in future promises to collect rent from whoever subscribes to any digital health platform. And this possibility of collecting rent on a regular basis from new intangible assets is one of the miracles of today's capitalism for those who have $28 billion, right? And my argument is that stultifies innovation, as well as extracting valuable assets from consumers and from the state, and that ultimately will lead to economic failure more broadly. You know, one of the consequences of the new IP-based capitalism is that it actually doesn't require employment. Basically, all it requires is existing assets, and so it doesn't generate innovation and employment. Now that may be fine; it reduces costs for a company, but keep cutting employment, keep making employment insecure, keep jobs low paid, and that's ultimately going to undermine the very foundations on which capitalism makes profits. So, I would just say that. Now, the question from the audience was, what do we need to change? And my view is we need to change the architecture of the international trading system. And the architecture is embedded in TRIPS, basically, and trade-related intellectual property rights. That introduction into the WTO of that rule is the thing that has created this parasitic economy. And until we change that, you know, we're going to go on having oligarchical companies making oligopolistic rents out of the assets of ordinary people like me and you who pay our taxes.
Thank you, Anne. And Chris, I want to come back to you. Can you give us a good example of a public sector so the question is, could you please mention a good example where the public sector and those involved in private equity have cooperated efficiently in order to either support projects becoming successful or just in general help health innovation?
Yeah, I saw that question actually. It's interesting because I think, you know, if we focus in on, I think the word efficiently was used somewhere there, right? Which is, you know, clearly, I think, you know, as we're discussing here, the role of private capital in the continuum of discovery through to, you know, the delivery of new ideas. I think and please correct me if I'm wrong, but I think what we're discussing here is sort of one of, you know, perhaps just how efficiently the system is working, as opposed to whether or not public and private partners can or should work together to do this, right? So, you know, and I don't know that I'm the right person to answer that from a systems perspective, but certainly from just to give examples of you know, the types of interactions or collaborations that we see. I mean, here at Duke NUS, you know, an example most recently was really around, we talked about COVID, right? The CPAS test that some people may be familiar with is a test that was developed in a lab of one of our professors, Wong Lin Fa, in 2020, early in 2020. I mean, I just arrived in Singapore, and he literally described the discovery of how to detect and measure not just antibodies against COVID, but neutralizing antibodies, the effective antibodies that that people develop. And he literally, it was the back of a napkin. I mean, it was, we had lunch and we were walking back from lunch and he was describing this idea. And we went back to the office filed on the idea and immediately began talking to potential partners. And the partner that we ended talking with was a US company, GenScript, that was looking to develop this into a diagnostic test. And so we licensed the patents to GenScript, but neither we nor, in fact, GenScript had the right expertise in-house to go from this lab-based, benchtop test to something that is actually in a kit. GenScript's expertise and capabilities was more on the distribution side at that point. And so we partnered with A*STAR, which is the Singapore government labs here that helped to productize this. And I think the argument is that without either the university or, in this case, the company or GenScript or the DXT Hub, which was the component of A*STAR that really turned it from a benchtop test into a product, that test would not be being deployed in the dozen or so countries in which it's being deployed today. Now, that's an example of a specific asset that was developed, and we have sort of many other specific examples. I sort of defer to others on systemically the efficiency of it, but certainly I can attest to the fact that in this particular case, it was done much more quickly than I've ever seen something go from an idea on the back of a napkin to a product that's actually been deployed.
Thank you so much, Chris. Great example. Well, I see we're out of time, and I can see we've got lots of questions, and we could probably do another session. But I just want to swing back around. And Ezra, you know, when you started out, you talked about private equity driving innovation, and you talked quite a bit about that. And then the kind of second question was private equity as a force for good. Ann's raised a number of kind of questions around that. What do you think? What would we need to do in terms of the governance to kind of balance out those perspectives? Do you have any thoughts on that?
Well, I do believe that a refocus on sort of rigorous corporate governance in privately held healthcare companies has actually been a sort of rather recent byproduct of some of the excesses which I pointed to, and that should be welcomed by everyone. The entrepreneurial community, the limited partner community, the private, the GP community, my general view is that we're at a point where there's a bit of a disconnect between the public market valuations of healthcare companies and the private market valuations of assets. And given that the private market frequently follows, albeit with some lag, the public markets, if the perspective is that the risk calibration of private investors needs to be sort of reassessed because they're not taking the appropriate risks, or the risk reward, sort of balancing, is not, being done, in the favor of society as a whole or these companies. I think what I could say is that there is a bit of a reckoning that we're sort of observing between the private markets and the public markets, and that's something that we look at with a fair amount of enthusiasm. I do believe that private equity can be a force for good in healthcare. I believe that unquestionably it is a force for driving innovation forward in healthcare, and that there are very positive types of innovation, alongside some not so constructive types of innovation.
Okay. Well, thank you so much. Fantastic discussion, great panel. Really enjoyed listening to all of you. Really some great takeaways. Again, thank you so much for your time. Have a lovely day, Ezra. Chris, have a good evening, and Anne, enjoy your afternoon. Take care.
Thank you.
Bye.
Thank you so
Bye.
much.